Welcome back to the Under Pressure podcast. I'm Dr. Jonathan Sacchio and I'm proud to be your host. Before introducing today's guest, it's important to note that this podcast is supported by Myo1, a Canadian medical device manufacturer. Please refer to the show notes for additional information. And if you have any questions, you can reach us at underpressure@nextsense.com. That's underpressure@nxtsens.com, and we'll put that in the show notes. So on to today's guest. It's my distinct pleasure to introduce Dr. William Obremskey. The good doctor holds several key positions at Vanderbilt. He's a professor in the Division of Orthopedic Trauma. He's the Director of Orthopedic Trauma Research and VUMC Executive Medical Director for Technology Assessment and Product Acquisition at the Vanderbilt Center for Musculoskeletal Research. Dr. Obremskey's career has been deeply rooted in the management of complex musculoskeletal injuries and the advancement of trauma care. With decades of experience treating high-energy injuries and mentoring generations of new surgeons, he brings a uniquely practical and thoughtful perspective to some of the most challenging problems in his specialty of orthopedics. In today's conversation, we're going to explore the realities of diagnosing and managing acute compartment syndrome, surgical decision-making under uncertainty, and broader topics including knee dislocations, scapular fractures, and infection prevention strategies with musculoskeletal implants. So, Professor William Obremskey, welcome to the Under Pressure podcast.
Sure, John. Thank you for the opportunity to be here. And maybe just before you get started, I have no conflicts of interests on any of the topics which we'll be discussing. And so there'll be no show notes about that.
Fantastic. What do they say? Sunlight is the best disinfectant. So before we get into some of the other topics, medical practice has many challenges these days. And I'd like to talk to you a little bit about supply chain and your role. Deploying new technologies in hospitals nowadays needs great patience with value analysis committees and economic factors distracting us from what we as doctors believe will help patients. I remember the old days. I would come back from a conference. I saw a new piece of kit and I told my very lovely OR nurse, Linda, can you please order these? And she'd say, sure, Jonathan. And bish, bash, bosh, it was done. Can you address this new world order?
Sure. Maybe a little bit, John, just how I got here. I got here when I got to Vanderbilt 24 years ago almost, that it was a little bit chaotic in terms of how stuff came and there was no process. Something like John said, that if you wanted something, you just asked the charge nurse or you bullied the charge nurse into ordering it. Hence we had 4 nailing systems, 3X fix systems, 4 plating systems within orthopedic trauma. And there was no real process. So we implemented a peer-driven and evidence-based, medicine-driven process for contracting for implants and also for technology. And now I sort of run that system for our health system. First, we started just in the OR, and now it's into robotics with our regional hospitals, which a meeting we had yesterday. Down to biologics of what biologic things, because they're surprisingly sometimes little science, and to try to make this a science and evidence-based decision and not a preference or a conflict of interest driven procedure process. So that's just how I got here, not intending to go down this path, but I got a sort of healthcare MBA along the way to maybe help me with that. So I can read a spreadsheet. To answer your question, everybody wants new stuff. We go to conferences, we see stuff, and it's interesting, and you may want to try it. But the bottom line, and you use the word distract, I guess I take offense to that a little bit, and I don't think that the process distracts us. I think that just because I saw something and I believe it to be true, that it may not be true. And that I believe, physicians and in medicine, I believe we live in a world of science. My grandmother used to tell me that stump water would get rid of warts. She believed that was true. and so it doesn't mean we need to order stump water.
Good point.
And other things of, in my career, I've seen many things come and go that we thought were good ideas and were bad. The carbon fiber joints, take your long list of things. And now we're into, robotics and total knees, or, what are biologics better than bone graft and spine fusion? What total knee, spine, or bone fixation implants are better, quote unquote. If any were better, then they were probably take over the market. And most things are really a commodity. So we tried to develop a process that was peer driven and evidence based medicine driven, so that the institution can, I think, make fiscally sound decisions and stay in business. And, a place like Vanderbilt, there's got to be a margin, or we can't do our mission of taking care of everybody that we need to. So I don't think it distracts us. I hope it makes us focus on accuracy instead of just desire. And we do have a process of, I went to that meeting. I want to try 5 of these. Maybe it's great. Okay, great. We'll do 5 and we'll contract for that, but we'll evaluate it at the end. Is the other process to maybe help facilitate that process, not carte blanche, everybody can use it, but you or your colleagues want a newfangled widget. Yeah, we often do that for 5 or 10 or whatever seems like a reasonable thing at a time at a reasonable price, not just list price.
Right, right. Um, Good point about distracting. I mean, I guess, yeah, we've got to be responsible in our departments. Of course, the issue is that when something gets to market, there's already a body of evidence, a corpus of evidence, but then it goes out into the real world, and we discover things that were not discovered in the studies that were done, which were, I believe that the vast majority of people have good intentions and are honest and ethical. But you discover things when stuff gets out into the real world. But economics, of course, is a very important, and you make a great point about needing to be profitable so that we can support everybody. So, Bill, you've spent you've spent, it's easy for me to say, you've spent a significant portion of your career managing complex orthopedic trauma whilst educating residents. Looking back, what initially took you into trauma care, and what's kept you engaged in this field over the years?
Yeah, I sort of came to trauma circuitous. I mean, when I went to med school, about the only physician I knew was our family doctor in my small hometown. And I literally went to the family practice interest group my first year of med school. But I had been involved with football as an undergraduate and had exposure to orthopedics, and sort of had made some relationships and really began to become attracted to orthopedics. And from my sports background, I mean, I was sure I was going to be an orthopedic sports medicine doctor, and was planning on, leaving and coming back to my alma mater and be the Duke ortho sports surgeon. I just found I liked different things. Um, one, some of us, you got to decide, do you like the same thing repetitive, or are you a little bit ADD and you like to do a lot of things? And in orthopedics, ortho trauma, and are one of those subspecialties where you can do a lot of different things. And I felt like in orthopedic trauma, we really made a difference in people's lives, and was very egalitarian. I didn't care who you were or where you come from, or how you got there. My job was not to judge you, but to fix you, and to give you the best opportunity to get back on track with your life as I could.
Yeah.
And within orthopedic trauma, you don't have to do it very long to know we got a whole host of things we can do a whole lot better. I say, sort of jokingly to our tumor colleagues, that I'm glad that when we have our monthly M&M, that the tumor team is also presenting, and that almost nobody has more complications than the tumor team, given the high incidence of infection and non-union that we see in orthopedic trauma. And we not only should, we have to make that better. I mean, our joints colleagues have an infection rate of 0.5%. And in published literature just 2 months ago, in a largest series ever in our national, the major extremity research group, where we have several thousands of patients, that our infection rate in high risk injuries of bad tibias, pilons, plateaus is still 20%. I mean, that's awful. We need to do better. And so I've had a lifetime of research trying to figure out how to do things better, and we've made a little bit of progress.
Right, right. Yeah, I see what you're saying. I mean, in general surgery, I loved emergency surgery because, on your way to the operating room, you had no idea what you were going to be dealing with. So I'm with you there. As a general surgeon, I taught my residents, Bill, that one rarely sees a textbook case of acute appendicitis or anything for that matter. Acute compartment syndrome is heavily emphasized in training, yet many surgeons say real cases rarely look like the textbook description. In your experience, what makes diagnosing ACS so challenging in actual practice, and what clinical patterns or contextual clues do you personally weigh most heavily?
Yeah, I think you're 100% right there that, we have this, vision, and I think it's mistaught at times that, people have a, tibia fracture and that they're writhing in pain and they can't talk to you, that they're so hurt and in so much pain and they have numbness and tingling and, you may not even feel pulses. But I almost never see that. And there's just such a wide variety of things that can cause a compartment syndrome, from prolonged leg elevation, DVTs, uh, and compression injuries, exercise induced. I've seen some weird things that have come up and made the diagnosis hard. Uh,
Actually, Bill, we've talked on this podcast about ECMO, and
yeah,
as someone who did a lot of colorectal surgery, now with robotic colorectal surgery with people with their
leg
legs
elevation.
rib shrouds, yeah, we're seeing it
Or
all over the
gender
place.
transforming care.
Yeah, yeah.
It's a long position in the elevated position, and we've seen a number of those,
Mm.
and they are right. They're relatively uncommon, and so I think that, one, keep in mind that it may not be routine, but two, it's the injuries that are really high risk, like the bicondylar plateaus, knee dislocations, proximal tibia complex shaft from a bumper strike. That these are things that we know have in some series, a 20-25% incidence of compartment syndrome associated. So anytime I see that injury, your antenna immediately go up, and this person needs repetitive exam, and over time, to be sure it doesn't change, because we know compartment syndrome evolves. And then your clinical exam, you talked about, I think the literature has shown that nothing is really 100% reliable, and it takes somewhat of a gestalt. The clinical exam things that, at least a little bit of data, is that it's the fullness, or I call it the extra P, the porkiness of the the reviewers wouldn't let us put that in the article, but it's I would call it the porkiness, just complete fullness of the limb. And then to me, it's numbness. When things start going numb, that's a little bit the canary in the coal mine,
Yeah.
and the tingling, the burning. If you wait, and pain, but pain. I mean, when your tibia is broken, it hurts. When your knee dislocated, it hurts. And so pain has been hard. And what one, as I tell almost every male who hurts themselves, and 75% of trauma is male. There's a reason men don't have children. We are not good with pain. And this person says, I have a high pain tolerance. I mean, I like touch them and they're like, ah. It's on the Y chromosome. It's not our fault. But pain is variable depending upon the person.
Right.
But numbness, pain, and this fullness, that it just feels really full. I think those are a little bit data free, but I would say that there is some data that they are indicative of, to when you raise your concern for pulling the trigger.
Yeah. Ed Harvey has talked about this, and when he first mentioned the term porkiness to me, I'd never heard it used in clinical medicine. I'd heard it used in culinary circles. And if you've never seen Jim Gaffigan's shtick on bacon as being the food magic, I commend it to you. But you automatically know what porkiness means.
Yeah, and I have to admit, I coined that, and Ed and I tried to put that in our big data paper,
Yeah,
but the editors didn't like that.
yeah,
They
yeah.
thought it was not, was it, you know,
It's not a
polite enough,
scientific enough word. Yeah,
right?
there you go. So the decision to decompress can urgent, stressful, and often happens in the context of team-based care. I'm curious about a very real scenario. It's the middle of the night. It's always the middle of the night. You're on call, and a resident, perhaps a very junior one, calls you worried about a possible compartment syndrome. How do you mentally approach that situation? What are you listening for in the resident's voice? What questions do you ask? How do you direct them? And how do you think about the roles of residents and nursing staff in safely navigating that uncertainty? When you and I trained, Bill, it was more of a team based care rather than a much more limited work week. So there was much more contact between individual residents and patients and the residents and the attendings. So can you think about that scenario a little bit?
Yeah, I think often, somewhat, you get the sense of the heightened urgency in their voice,
Yeah.
and I asked them what the injury was and what the exam seems to be. And then literally sometimes I just ask them, what do you want if it's you or your family?
Good question.
And, I don't care if it's 2 a.m. And, because if they're raising the flag to call me at 2 a.m., they're concerned.
Yeah.
Because, I think the systems have been developed that, at least in our system, that there's needs to be a high bar. There is a high bar. And then, again, what am I listening for? I think, what was the injury exam, and have they seen them more than one time?
Yeah.
And has there been a change? I think, is what's really important. Is there a change? And then again, I ask them about, pain, numbness, porkiness, although, and again, the trend or change.
Yeah. Yeah. So, I was always such a conservative guy that if I got a call, I more often than not just said, "Oh hell, I'm going to come and see the patient myself." But
Right.
it's very, very difficult. I can imagine if you're operating and a resident sticks their head in the OR and says, "I've seen this patient," and then an hour later it's another resident who sees them. So that discontinuity, I'm sure, doesn't help. But let's move on to
So
so the
I
next
have
one
one
is. I'm
one
sorry.
more
Go ahead.
comment on that.
Yeah, sure.
That, it's not their fault. They're early in their career,
Yeah, yeah,
and they probably haven't seen many compartment syndromes.
yeah.
And so if they call me and raise the flag, I'm probably coming in, or I'm just calling the OR and tell them, hey, we're going.
Hmm.
In the world of general surgery, maybe you accept a 10% false positive rate
Yeah,
of,
yeah, yeah,
appendicitis.
yeah,
You know,
yeah,
you raise the flag. You don't want to miss one
yeah,
because of the,
yeah,
the sepsis risk,
yeah,
and the risk of missing a compartment syndrome is far from benign.
yeah,
And so I try to err on, if you think you're worried, then I need to be there, or your senior needs to be there. And in our system, we teach the residents to load the boat, get somebody else to look, ask a friend, you know, call your senior, have your senior come in. We're a layer deep with a fellow, or me. Or if you're calling me and you think it needs to, you would want it done, and I say, what do you want for your family? They say, I want an operation. I'm like, we're going.
yeah. There you go. It's a great way to learn. But as we all know, fasciotomy is not a benign procedure. Um, Although it can seem straightforward for trainees or early career surgeons conceptually, but complex in execution. What about technical or judgment areas that you've seen in your career?
Yeah, I think as we're talking, the biggest judgment error is delayed decision.
Right.
It's an evolving. This is not an on-off switch.
Yeah.
And it's amazing in one cases where you see compartment syndrome and you open it up, it's not black and white. It's not all alive or all dead. I mean, I've seen speckled, where you see sort of some areas are sort of pink, some are alive, and different fibers. So it's surprising, even in different fibers within the muscle may be alive or dead, or different aspects of it. It could be the distal or the middle or the proximal aspect of it that appear to be more significantly affected by the elevated pressure. in the compartment. So I think it's a delayed decision because it's gray. If we lived in a world of black and white, we wouldn't need lawyers, and so we need some judgment.
Yeah.
And the technical errors that I think I see is most commonly is incision too short. If you're getting compartment syndrome, you're getting a 30 to 40 centimeter incision on the side of your leg.
Yeah.
Incomplete release. I have come back, particularly with some of our colleagues in vascular or trauma, in that they do these relatively small incisions, and then they want me to take over. I'm going for the tibia fracture, and they have done a compartment release, and you open it up wider, and the muscle's dead at the proximal or distal end,
Yeah.
where they didn't release.
Yeah.
So I think a very long incision, and then it's to send, are you a single or a two incision believer? I think the basic science, the clinical evidence is clear. You can do either, both work. The U.S. military teaches dual incisions, medial and lateral. I teach single long lateral incision. It's clear you can get to even the deep posterior through the lateral incision, primarily because the fracture patterns that most commonly have this, knee dislocations or tibia plateaus or tibia shaft fractures, often have contused medial skin. So then you're cutting through damaged tissue on the medial side,
Right.
and it's a little bit of insult to injury and may lead someone to needing a flap, where if we didn't touch that skin and just alleviated the pressure, they wouldn't need a flap on that.
Yeah.
So that's why I often go single long lateral, because it's effective and it eliminates that medial skin, which is clearly thinner and right over the bone.
Yeah. Some good points. So let's say you discover a non-viable compartment. How do you approach the situation when, for example, the anterior compartment is no longer salvageable?
Yeah, I think just it's best to keep in your mind what your goal is, to prevent infection and to get them to have as functional leg as possible. If it's been, is this, is it not? And you get there, or they got transferred in and they arrived, and you're like, oh, we got to go, and you go to the OR, and it's in clinical exam preoperative. I think is important. If clearly they have plantar flexion, they have normal feeling on the bottom of their foot, but they're missing anterolateral feeling, and they can't dorsiflex their foot, then I'll make somewhat of an incision in the mid part of the tibia, and then just look at the anterior compartment. And if the whole thing is dead, and it just is clearly dead, then I'll just close. I call it peek and shriek. You can close it, and then because it's clearly there's no motor function, no nerve function, that you're too late. But the rest of the compartments seem to work, the deep and the superficial deep, and you can live without an anterior or an anterior or a lateral compartment, and just use an ankle brace and be okay. So the peek and shriek, if you're in that zone, if you open it up and you've opened it up and you're coming back and some muscle you thought was alive is dead, and it's patchy and you have some alive, some dead, I at times will try to debride as much as I can and then close the skin, because you can't skin graft on dead tissue.
Yeah, sure.
So what are you going to do? So I try to debride as much as I can, and to the point where you can then bring the skin together and seal it off. And a small percent, I wish I knew that number, but it's been so rare, may become infected and then have to have an OR open and bring it. So you're just back where you were.
Right.
But the vast majority of the time, I've been able to get away with that, to debride and close. And then if they're really so swollen, it's like they're never going to close. If you just do a partial debridement, I'll just take out the entire anterior compartment. If it's all dead, you can take it out. It still bleeds a lot because the small vessels are fine, and the large vessels are fine. It's the cellular that just causes cell death. So people think, oh, geez, there's blood flow, but it's dead. It's not. That's not the problem.
Yeah.
Is that the pressure killed the muscle, and you decompressed it, and so now blood flow is going through those capillaries. And so I have taken out the entire compartment and done one of two things. You can either do I call it a negative pressure drain, where you put a drain in the anterior compartment, you close the skin, and you put an incisional negative pressure dressing
Right.
over the skin, and that
Right.
helps suck it from deep and try to decrease the dead space and prevent the infection. The other thing I have done is mobilize the lateral compartment in a really bulky person, a large male. That anterior compartment is such a huge divot that it's a problem because it's such a big dead space. So then I have mobilized the lateral compartment, moved it into the anterior compartment, closed the skin partially, and then skin grafted what was left of the live lateral compartment, because you often then can't close it completely. So to prevent that huge dead space, I sort of fill the dead space with the lateral compartment and then skin graft over the lateral compartment. Those are just some technical things I put in a chapter or two that I've written on compartment syndrome as just technical tricks to try to do.
And that all makes perfect sense. And in terms of functional outcome, you said you can survive it. Obviously, you can survive, and it's better than the alternative. But just an ankle brace because of the lack of dorsiflexion.
Right, and I live in Middle Tennessee, and the country music capital of the world, and so a lot of people just wear cowboy boots, and they don't like an AFO, but they're wear a cowboy boot, or they wear a work boot, which they just lace up work boot, sort of functions. Both of those can function as an AFO.
It's interesting you mentioned that. A colleague of mine had a foot drop for a different reason and always wore cowboy boots.
Yeah.
For that very reason.
I would say less than half of the patients that end up with a loss of anterior compartment functionally end up with a tendon transfer.
Right.
Most, I would say, use an alternative foot shoe design. Some use an AFO, but most people don't like to use an AFO long term. And the very small percent that are maybe higher level people that want to be an athlete, and they tend to get a tendon transfer.
Sure. So you recently studied how variables like age, sex, and fracture location affect continuous compartment pressure measurements. It was published quite recently. Could you distill that work for us? And what were the most important findings that clinicians should take away from it? You did say earlier when you're talking to the resident at 2 a.m., it's normally a young male that's had the trauma because I think as the males of the species, we're a little bit more reckless, possibly than.
Well, I think it's not just it's muscle mass.
Yeah.
I mean, this is muscle mass injury, and I think and males are also less flexible. I think that's sort of face validity, and so our collagen is more tightly cross-linked, and so there's less extensile capacity of it. And I think E is the answer, all the above. Males are more reckless. 75% of trauma is male. If you look at any registry, they tend to be younger because they're more reckless. And then the tibia is one of the most commonly
tibial plateau. Yes.
So all those, yeah. So that combination leads to a higher propensity there, but also it's just that the muscle mass in a confined compartment there. So young male proximal tibia are my triggers at conference every morning. And so that it just raises my antenna because of that, and I think it's a muscle mass and an injury predilection.
Right.
The other things that I think have been really important within the literature are that no single the single pressure measurements, and my friend Tom Large wrote this years ago, that have a very high failure rate and an unreliable rate. It was a model, cadaveric model, and I had to look it up just again this morning to refresh my memory. Up to 60% of measurements made, had a critical, or 40% made with a critical error, and only 60% were made within the correct technique and within 5 millimeters of what was the known pressure. So it's highly variable. And, I tell the residents, if you've got a pressure monitor in one hand, you better have a knife in the other. if you come to stick this person, and because we know that that single pressure measurement is not that reliable. I mean, we've all done it. Put in too much, too little. It's up against the bone. It's up against the fascia. It's just not that reliable. Um, and we don't really even know what the right pressure is. You know, is it pressure greater than 30 absolute? Is it a delta P of the pressure versus the diastolic pressure? I mean, what's been published is 20 millimeters, 30 millimeters. And is it 30 millimeters, under anesthesia or in the awake state? And, the Margaret McQueen, definition has been delta P less than 30 compared to diastolic pressure prior to anesthesia. you know so if you're measuring in the OR, it may be very different. And so we know that all these measurements can give you a high false positive or a high false negative. And we can talk about it a little bit later, but I do think that the trend is in what is occurring in the pressure, and which is then reflected in the exam if they're awake, is much more reliable.
So it's the combination of continuous pressure monitoring and clinical examination over a period of time.
Yeah, but in trauma, we don't always have that privilege or luck in that a fair number of our patients with these high energy injuries are intubated, sedated in the ICU,
Right.
and we can't tell. And so we're, looking at other things of, what's their systemic lactate, and, is that due to physiology or due to local injury? What's a CPK? Is that physiology from general trauma, or is that the local injury? We don't really know. And so it makes it very, it's made the diagnosis challenging, which is why we're having this conversation.
Yeah. So key findings from the papers, just
young male proximal tibia.
Yeah.
And trends.
Okay, cool. Well, let's change topics a wee bit here, Bill. Knee dislocation, another high-risk injury where timing and vigilance are critical. What makes these injuries particularly dangerous, and what do clinicians sometimes underestimate? I recently saw one at what we call a football match, different kind of football. We use a ball in our feet, but yeah, terrible injury to see. So yeah, talk to us a little bit about that.
Yeah, I think, we think they're not very common. My belief is that they see people in trauma centers more than we see them. And I've got 3 this week that I did one last week. I'm operating a guy who had bilateral knee dislocations today and bilateral leg vascular injuries from getting run over by a paver. And so the problem is that I think that they often come in and they are, they've auto reduced. And so our antenna is not high. I mean, we know that about 15% of these people have a vascular injury, and that if it gets missed or delayed, that they end up with an amputation. And unfortunately, a guy over the weekend presented, 6-8 hours after his injury. Our vascular team spent 12 hours trying to get his flow. They got flow, but he's got a dead leg, and he had an above knee amputation over the weekend. And so that's just, we've had 4 in the last 10 days here at our trauma center. And so I think they're more common than we think, and that we miss them at times because of all the other high energy injuries. And, in the orthopedic trauma literature, it's pretty clear that it's 10 to 15% of people with hip dislocations, femur fractures, distal femur, proximal tibia, tibia shaft, have a ligament injury of the knee. It may not be a complete knee dislocation, and we know that 15% of people have a vascular or a neurologic injury of the knee. And so again, the injury, always assess them, and that's part of our routine. Is after you nail a femur, length, rotation, ligament exam, are the things you need to look at.
Right. So this next question topic's pretty personal to me. Recently, a very dear friend of mine called me from Italy having suffered a fall and fractured scapula. The docs there wanted to operate, and he wanted my advice. And I called one of my orthopedic trauma buddies here, who said, "Get him back here." I sent him the X-rays and everything. He came back to England, and it was managed conservatively. And here he is, I think, 10 weeks on now, and has made a great recovery. Scapular fractures often spark debate about operative versus non-operative care. How do you evaluate which patients truly benefit from surgery?
Yeah, this has been one of the injuries I've had an interest in, and wrote the modified Jude approach almost 20 years ago, um, and just wrote a chapter on scapular fracture approaches that was published in the last year. So I've had nobody has a large experience of doing these, and the good news is about 90% of them don't need an operation. Sounds like your friend is doing okay. And I will say I have tightened my criteria over the last 20 years, in that becoming more, a worse injury requires an operation. And you can tell you the things in the literature are that, translation of the lateral border of the scapula and the glenoid. When I was a resident, we called it medialization. Like the lateral blow, the glenoid got pushed medial, and we were wrong. And I knew that when I started doing some of these early in my career, and the reduction is you medialize the lateral border
Okay.
when you're
All right.
fixing these. You don't lateralize the glenoid for the vast majority of these injuries, and so we had the nomenclature wrong. And I think Bill Ritchie wrote an article, I wrote an article, I think identifying and causing, and now we call it translation, not medialization. There is the I call it the thin glenoid, where it breaks just through the glenoid neck. That does tend to fall anterior and medial. Or if the clavicle is broken and it medializes, then the entire complex, particularly with rib fractures, can medialize. But in general, the isolated scapular body does not medialize. It stays, the glenoid neck stays where it is, unless it's separated from the rest of the complex or the clavicle is broken to push it over.
Yeah.
Small point, but I think conceptually important. And when you assess translation, and translation now probably have to be 3 centimeters translated. But how do you measure that? On plain films, it's really hard because unless you get a Gracie view, a really good Gracie view, it over or under represents the translation.
The shift.
I think the 3D modeling has made it much easier for us to spin a 3D CT and get a much better idea of that. But just if you're looking just at X-rays, and then angulation, and that's probably in the 30 to 40 degrees on the lateral, with the scapula angulation on the Y lateral, so that it's not such a crook, and then glenopolar angle. Normal is around 40, 35, 40, and when it gets below 20, I think there's data that shows that then you have some shoulder dysfunction. And these quote unquote displaced scapula fractures, how do they do? Well, we know from older literature that about half the people with a displaced scapula body fracture will have shoulder dyskinesia. The reality is we don't always know which half you're in at the time, and it's really hard to fix late. So one, I look at the radiographic criteria, and then clinical exam I think is really important. Those people who can't generate force to move their arm, that they're really trying, but it just won't go, tells me that the relationship of the sarcomere, the muscle tendon relationship has been altered. If the scapular body has lateralized, then you can't generate force because your sarcomeres are not able to adjust that much.
Right.
So inability to use the shoulder, and that doesn't appear pure pain generated. And then even people who have those may not want an operation. I mean, in Middle Tennessee, we got a lot of Christian Scientists and/or Amish who just don't. This is my fate. This is where I am, or I don't believe in medicine or surgery, and they don't want an operation. Well, that's okay. Or had some very naturopathic people, and the patient's risk tolerance has got to want a fairly large operation. I call it medium to large operation.
Yeah.
The complication risk is fairly low. Infection rate is really low. Um, and they can go home and think about it. I've had people go home and think about it and come back in a week and like, hey, this isn't getting better. I got to do something. I will say it's easier to do within the first 3 weeks. After that, the scapula has such great blood supply; it's just sticky, and it's hard to mobilize.
Yeah.
And I think Peter Cole has taught us that malunions are really hard, and he's got a nice series of those. I think is going to be published. But you can do a malunion, but man, that's an operation I've done a few times that I don't want to ever have to do that if I don't have to, because it's really hard. It's much easier to do it than the first 3 weeks. So sometimes people just need time to realize they want, or they just know they can't move their arm. And it's remarkable. Once you put the muscle tendon length back in the right position and you do it with an approach that isn't really destructive, it's more MIPO. I think a number of techniques are described where you're going between the muscle planes and not necessarily scalloping them out, that they immediately are moving their arm after surgery.
Yeah. Yeah. Well, you're
So
just,
I would say my indications have tightened and my technique has changed to be much less destructive. And I think you can do these the vast majority without taking down almost any muscle. You can do it in the intermuscular planes,
right.
and get a good reduction, and allow early passive active range of motion.
So your descriptions really helped me visualize it. My buddy said to me that if it turns out his golf swing has been impeded, he'll hold me responsible.
Yeah,
So,
you
oops.
got a 90% chance you're okay.
Yeah, there you go. So you've mentioned infection a couple of times, Bill, both in the implant world at 0.5 and in the trauma world of 20%. Any strategies that might make a meaningful difference in reducing infection risk? And, putting that in the context of a world where we've got increasing antimicrobial resistance as a problem.
Yeah, and I think this is where within ortho trauma we have huge opportunity to improve the quality of our care. And last night the Orthopedic Trauma Association, we voted to engage with a number of other organizations into making clinical practice guidelines for infection prevention in open fractures. I've taken part in sort of guidelines with the OTA, the U.S. military, international AO group, and I think it's just because we know we have a problem, and we should do all we can to improve it. And I would maybe give you a couple things. One that's maybe my data-free opinion is that clean, sharp dissections, I think, are better in terms of decreasing the surgical insult, and less use of a bovie for dissecting, and knowing your anatomy, so you're going in the planes and not destroying muscle, or stripping bone. No blood, no heal, and no blood, no antibiotics, and no blood getting there, increased risk for infection. So I think we as surgeons have some opportunity in our dissection, to doesn't mean you make it with mini incisions. I think a much longer incision with clean dissection and less raunch it around with things is much better than a mini incision where you sort of do more damage because you don't want to make a big incision. So clean, sharp dissection, my data-free opinion. Data-based things that are done are just administration of early antibiotics. I mean, in open fractures, they should get antibiotics in an hour of hitting the ER. That's been shown. We know that infection rates increase when time in the OR is more than 2 hours. There's clearly an inflection point. We've met the enemy. It is as us. The bacteria come from our environment, from us. As males shed a lot of bacteria, and so the longer the wound is open, the more risk that it is. So trying to be efficient, or when you open an incision, if you have multiple procedures going on, you open and close that incision as soon as you can. You don't leave it all to the end. So close your incisions as soon as possible. Irrigation. This has been going on since Dr. Fleming who invented penicillin, did some great work in 1917 in England, that looking at all different types of irrigation, and really his conclusion was that saline was great. But we know in modern that saline is not very good at really decolonizing the wound alone. So there's been a flood of marketable things on, but the data is that dilute betadine with or without peroxide in the mix seems to decrease the acute colonization, but you also want to look at the rebound. What it is. We get focused on this, initial debridement, and we found that Pulsovacs are very good at debriding and removing bacteria, but they have a much greater rebound effect because we drive the bacteria into good healthy tissue where they got lots to eat. And then when you come back, I mean, the ISR in San Antonio, the military, U.S. military did that work. My partner Dan Stinner, right in the office right there, did that work when he was a resident and junior faculty. And so we know that you can cause greater infection with Pulsovacs, but irrigation does seem to decrease colonization acutely and decrease colonization on the rebound. And you have to walk this line between doing it without causing extra damage to the the native white cells that do more damage than it, because everything we do is toxic. Peroxide's toxic, betadine's toxic, and the solutions have been published in terms of what they are, but that's just the science just published last year, that those two solutions and the cost of those is way less than anything on the market, and all the fancy different types of diluting agents, even the quote unquote sterile dilute betadine. I know Jay Parvizi, I trust him, but I still have a hard time understanding what the difference between my homemade betadine and bottled betadine is. I've read the studies. I know the difference, but
Yeah.
I think if you're going to do evidence-based medicine, that you can base your evidence on decreasing colonization, can decrease your potential risk for infection. It hasn't really translated to decrease infection rates, but I think that data is maybe coming.
I have to say, I love this term, my data-free observation. I've got one for you. My data-free observation is I loved putting peroxide in a wound and watching it bubble. I just felt
Yeah,
like it felt like I was doing something.
scrubbing bubbles. Yeah.
Bubbles, exactly, curing bubbles.
When you put betadine, it's sort of like scrubbing chocolate,
Yeah,
Or,
there you go.
but the other things that have definitely been shown in level 1 data is local antibiotics in
Yeah.
high-risk wounds,
Yeah.
and negative pressure therapy on wounds once they're closed. I mean, both of those are shown a 30% decrease in infection rate,
Yeah.
but there's not been widely
Deployed.
implemented
Yeah.
in the orthopedic trauma world.
Yeah.
And the other, I guess with a little bit of data, the flow study looked at, antibiotics, extended antibiotics in highly contaminated wounds, and a retrospective subgroup analysis showed that antibiotics up to 72 hours in highly contaminated wounds, both open fractures, maybe had a decrease in infection rate. So usually it's short, 24 hours. I think in the next wave we'll do it even less, 12 hours, local antibiotics. I think we'll have some implants that have antibiologic properties. We'll have other things besides irrigants that put in the wounds that stay longer. And seems if Christina was right 50 years ago, it's a race to the surface. If you can protect the surface of the implant and protect the surface of the damaged tissues for probably 72 hours, that's a data-free opinion, but somewhere in that range, that the eukaryotic cells colonize, repopulate, and then bacteria have a much harder time getting a beachhead.
Yeah. So trauma care increasingly integrates objective data monitoring tools. What's the balance between clinical examination and adjunctive measurements evolving in high-risk conditions? We've mentioned compartment syndrome. Any others?
Well, I think just focusing on compartment, I mean, we know that we get it wrong way too often, and with the delayed diagnosis, and even here at one of the busiest trauma centers in the country, we had a patient admitted for exercise-induced concern and sent home and missed it. I think because the resident and the faculty member were young and not experienced in compartment syndrome,
Yeah.
and it's an awful outcome
Yeah.
for that patient. So we know we get it wrong, and these are relatively unusual events with a high variability in what can cause them. We all think the classic, young male with proximal tibia. Okay, we miss fewer of those, but I've seen it in bilateral DVTs, from plug vena cava, bilateral compartment syndrome, hematomas. Everybody's on Eliquis or some sort of anticoagulating ad if you're over 60, uh, and and these sometimes have spontaneous bleeds, or they get a traumatic injury and they bleed a lot, and those can, the missed knee dislocations that, think, oh, it looks like a reduced, just people who walk 20 miles but they're not really very fit, and they get, exercise induced compartment syndrome. And then, as you said, the leg elevation from GI and GU procedures, and then the obtunded patients, that
Yeah.
we see. And the problem is, our measurement tools are pressure, and it's just a surrogate for physiology.
Yeah. Yeah.
We really need a measurement of local physiology. Even measuring CPK is measuring, distant. It's systemic CPK,
Yeah.
and not local muscle death.
Yeah.
And the trigger is supposed to be 5,000, but it's not 100%.
Yeah.
5,000 is associated with increased risk, but not 95%.
Yeah.
And so in all of these, we're looking at surrogates. We really need to look locally for pH, lactate, some other biomarker, either systemic or local long term, which I hope we can. And I think that we know that our single pressure monitors aren't very useful and have a high failure rate. And I've studied those, and have been part of some work in using those. And I just think they haven't really panned out, and I almost never do that. We were talking about, although this is sponsored by Mile One, I do think it's a better mousetrap, and a better technology to give you more accurate readings of what's going on in a compartment at the time. And again, I think the recent article that we published on that really identifies that the trend is what's so important. And I mean, I've seen people with intercompartmental pressures that I have put a monitor in, and I come out and I look at him in the cover room, and it's 50. But he's sitting there looking at me, having a sandwich, talking, no pain, moving his toes. But in Margaret McQueen's world, or in the absolute pressure world, that we should be rushing this guy to the OR. But he has no motor sensory changes, no pain. He's got a full leg because he got a tibia fracture, but it's not, it just didn't fit. And this is why. But over time, it slowly comes down. And I think the data in the article that was published earlier, I think indicates that, at least in my world, the best evidence is trend over time in an exam and pressure.
Yeah.
That's what I would encourage our residents to do.
So, just a parting note on advice to residents: how do you educate them to navigate uncertainty, if you will, without being either overly aggressive or dangerously hesitant, to tread the positive,
Yeah,
perfect course?
how did I get experience? Probably by making bad decisions.
Yeah, there you go.
And I think my strong advice to residents and any junior faculty or junior person is, don't be proud, and ask somebody with more experience than you. And because it's a huge decision that has severe consequences if you miss it. So call your junior, call your fellow junior, call your chief, call your fellow, call your attending, get as many pieces of advice as you can get, because if it's missed, it's a life-altering event for that patient, and we
Yeah.
don't want to miss that. And being and the other side has consequences too. A big cut in the leg, clearly lengthens time in the hospital, a couple days, and OR trips are expensive. Big gash on the leg is better than missing a compartment syndrome, but has consequences in and of itself.
Fair to
So my
say,
strong advice is just ask somebody else, because they're not that common, and nobody's seen 1,000.
yeah, yeah. Hubris has no place in medicine, yeah?
Right. I think someone
So,
said that hubris is the greatest sin of humanity.
yeah, you got that well. There's quite a few, unfortunately.
Yeah, well,
Sadly,
one
Bill,
of
that's
many.
all we've got time for today. So it just remains for me to thank Professor William Obremskey for joining us today and sharing your work, all you've done, all you'll continue to do for patients, and for teaching me a new phrase, a data-free. I love that. I really do. Thank you so much.
And porkiness. And you
And
learn
porkiness.
porkiness,
There
a
you go.
word in a phrase.
Yeah. And I've recommended Jim Gaffigan's bacon routine. It's one of the funniest things on the internet. Well
All
worth
right.
it.
Well, thank you.
Thanks a lot, Bill. So, to our audience, thanks so much for taking time out of your busy day to listen and demonstrate a desire to see better care for your patients. Please share this with your colleagues, post on social media, write to us with comments, questions, or suggestions of other podcasts that we might do at underpressure@nextsense.com, underpressure@nxtsens.com. Thanks also to Maya One for supporting this podcast. And all that remains is for me, your host, Jonathan Sakia, say thanks for joining us. Please stay safe, stay well, stay curious. Bye for now.